So Dr. Ankur needs no introduction. He is director and senior medical oncologist in Fortis Memorial Research Institute, Gurugram. So he'll be talking on role of adjuvant and neoadjuvant chemotherapy in early and locally advanced colorectal cancer, followed by panel discussion, which will be moderated by Dr. Nagender. Dr. Nagender is a senior medical oncologist in Medanta, Gurugram. And the renowned faculty would be Dr. Saphalta. She is from Amrita Institute of Medical Sciences, Faridabad. She is a senior medical oncologist. And we have Dr. Viraj with us. Viraj is from HCG Ahmedabad. He is also a senior medical oncologist focusing primarily on GI malignancies. We have Dr. Prashant Gupta, and we have Dr. Ankur Bahl as the panelist also. So I welcome you all. And Dr. Ankur, please start the lecture.
Yeah. Thank you, Dr. Shefali, and compliments and acknowledgement for this 42nd webisode. It's a huge thing in GI oncology. So you have given me a topic of role of adjuvant and neoadjuvant chemotherapy in early and locally advanced colorectal cancer. I may eat up 5 to 7 minutes extra. Please allow that, but it's a huge topic. And
sure.
Okay. So the outline will be, I'll be taking you from like 15 to 20 years journey of colorectal cancer in adjuvant, regimen, various trials. Then we'll be speaking on biomarkers and efficacy, the selection criteria, which is changing hugely. And now the recent, I will be digging on some COBRA trial, ACT trials of CTD DNA, role of neoadjuvant chemotherapy, the ASCO 1920, which got it shaded away in COVID protocols. So, and then we'll see who are the candidate for neoadjuvant chemotherapy, the area which is still being not very much touched. So colon cancer, as we know, is a very common cancer, and in our OPD, so they are our long-term survivors also, and they are our relapsers also, a leading cause of death in our country as well. In localized colorectal cancer, and now we call at locally advanced colorectal, and so there are some subsets which we'll discuss. So lymph node invasion is a major prognostic factor which defines stage 2 and 3. So overall survival in stage 1 is far beyond 95%, stage 2 70%, but it drops down significantly to 45 to 60% when it comes to stage 3, which is around 1/3 of our patients. So if I say 100 colorectal cancer patients receiving adjuvant chemotherapy, I would say still 30% of the patient may benefit from adjuvant, majority may benefit from surgery, and in 20% we are probably overdoing it. So in stage 2 colon cancer, we probably treat many to save a few. Who requires adjuvant chemotherapy, what are high risk stage 2, what are low risk stage 3. 3 months versus 6 month idea is old now. More chemo for some and less chemo for many. Can we detect recurrence? And how do we do a surveillance, and how do we justify stage 2? So this is the point of concern. This is a meta-analysis published by Baghmar in 2015, who clearly says that stage 2 without adjuvant therapy and stage 3 without adjuvant therapy, there's a difference. But with adjuvant therapy, we can get a survival benefit in stage 3. You can see it was 49% without treatment. And when the treatment was given in stage 3, the 49% reached to 63.6% or 63.6%. So adjuvant therapy has clearly dealt, which has been proven that it increases survival when it is a lymph node positive patient, stage 3 patient. However, stage 2 colon cancer, 4% can be cured by chemo if there is an MRD or the chemo sensitivity. 80% can be cured by surgery alone if there's no MRD. However, 16%, 15 to 16% of the stage 2 colon cancer recur despite chemotherapy. They are MRD but chemo resistant, and Viraj will agree that probably they are BRAF mutant. So we have been discussing in our tumor board what is the right timing of adjuvant chemotherapy. There are papers which says that even 2 weeks after laparoscopic hemicolectomy, we should be aggressive and start, particularly in lymph node positive if the performance status allow. But if the delay in initiation of adjuvant chemotherapy is beyond 8 weeks, it decreases overall survival. However, patient can still benefit at times when there is some anastomotic leak or morbidity after surgery. We still say that there is still a benefit of adjuvant chemotherapy if it is delayed up to 5 to 6 months, but the effectiveness decreases when the time elapses more than 8 weeks. So we strongly suggest that uh, adjuvant chemotherapy should be initiated within 8 weeks, 2 months. But as a practice in various institute which I've worked, we start at 3 to 5 weeks or 4 to 6 weeks. So I'll take you back to when there was only 5FU. The 3-year disease survival was less. Many attempts of various exact trial and many other trials, which I'll tell you, capecitabine versus 5FU leucovorin, there was no difference. 5-year difference was okay. So this mosaic trial, which was actually a randomized trial between 5-FU leucovorin and folfox 4, which I mean there are uh, we are modified folfox 6 8. So it was clearly shown that those patients who got oxaliplatin along with 5-FU leucovorin, they had a better 3-year as well as 5-year, and it was published 15-16 years back. So there is no doubt then oxaliplatin when added to 5-FU leucovorin increases DFS and increases OS. And we can see here in the graph, when stage 3 patient given Folfox as compared to only 5-FU leucovorin, the orange graph is far better than the white graph, clearly depicting that adjuvant oxaliplatinum increases the survival probability both in OS and as well as in PFS. But yes, oxaliplatin comes with toxicity, but we are so much mature in Folfox, both in gastric, colon, and various other cancers. So Folfox, I consider in my practice, initial 8 cycles are very easy. The problem starts in 9 to 10 cycle when amount of neuropathy, particularly in diabetic, and also we are very well versed with Folfox, and we proudly give Folfox. It causes no alopecia or grade 2 alopecia only. So long-term safety of Folfox is very much known to us. So there were many attempts in last 2 decades, and big number patient, 2,500 patient randomized to 5-FU leucovorin and Flox, a modification. So we can see that by adding oxaliplatin, there is 21% risk reduction in the DFS, and other attempts of Zelox, Capox, or 5-FU leucovorin clearly says that by adding oxaliplatin, we increase the OFS or DFS as OS. But yes, the recurrent risk and the time has changed now. We want to identify a high risk stage 2 and low risk stage 3. When we were students and we were training in early years of our practice, we used to say stage 2 and stage 3, node positive or node negative, and we used to identify risk factors. But now we have stage 2 and stage 3, which are high risk stage 2 and low risk stage 3. This is the era where we can identify these patients and give them justice by giving adjuvant chemotherapy. So stage 2 patient defined as high risk are T4, bowel obstruction, tumor perforation, poorly differentiated venous invasion, and so on. And we clearly see that 5-year disease-free survival in stage 2 high risk when given adjuvant Folfox compared to 5-FU leucovorin, there is a delta of 7.2%, although hazard ratio was 0.74 and the confidence interval was crossing, but there was a trend towards adding oxaliplatin. And many attempts in last 3 years or 5 years have been done to actually, an NCCN guideline has been so well versed in stage 2. So tumor block reassessment on the biology, MSS, MSI, loss of heterogeneity of 18q, Folfox observation, single agent capecitabine, attempts of even adding targeted therapy to Folfox with bevacizumab. So these are future directions. So there have been attempts even in stage 2 to stage 3 by adding a bevacizumab or a cetuximab. This is NSAPPC08. This is Avant trial, which was Folfox, bevacizumab, Zelox, bevacizumab, capecitabine, bevacizumab, folfoxcetuximab in stage 3. So all these, the Accord trial, Folfox versus folfoxcetuximab. So many attempts. So this is a summarize of phase 3 trials in adjuvant treatment of colon cancer, Impact, Exact, Mosaic, PETAC, CalGB. So much has been dealt, and it has been clearly proven that the world has moved on 5-FU leucovorin, beyond 5-FU leucovorin in stage 3. So one point which I think Nagender will deal MSI status. So a total of 9 to 10% of our stage 3 cancer have microsatellite instability. And we know that microsatellite instability in stage 2 is a good prognostic marker, but the value of this MSS or MSI is still not clear in stage 3. We also know that MSI tumor has a higher frequency of BRAF mutation, and now the world is moving in stage 2 MSI. They are actually dividing with BRAF mutation or not BRAF mutation. So it is a well-established biomarker even in stage 2, stage 3. So we need to select these patients for adjuvant chemotherapy, which are high risk, node status, a biomarker status. And so this is what I was saying. So colon cancer, stage 2, stage 3, stage 2, MSI unstable, MSI stable, again divided into PT3, T4, LVI, PNI, low risk in gene expression signature. So we are actually moving towards what Peru et al. Did in breast cancer and was like oncotype DX and luminal A, luminal B, HER2, basal type. So colon cancer, we are maturing enough to identify high risk stage 2 and low risk stage 3. So this is 2022 colon cancer. So T3, T4, T1, node negative, MSI high, deficient, observation, MSS stable, MSS stable, observation versus capecitabine. So once this, so we are well versed with MSI and MSI status. It looks like confusing, but if you practice it 3-4 times in your just 5-6 patient of such stage 2 or stage 3, you will be understanding what MSI and MSIS is. So now, so we have been practicing MRD in our leukemia patients. So now the era has come where in solid cancer, MRD can be practiced. So what is MRD? So there are a subset of the patient who are cured, but when there are 10 raised to power 5 cells in the body, which can not detected by imaging or ctDNA, or once they are 10 raised to power 7 detected by ctDNA, it is called as minimal residual disease. So once it is detected by imaging, it is a gross residual disease. So ctDNA can define minimal residual disease after surgery. So this was a dynamic trial in 2022, clearly stating that the 3-year recurrence-free survival was 92% among ctDNA negative patients who do not receive adjuvant chemotherapy. I'm repeating, after surgery, those patients of stage 2 who did not receive adjuvant chemotherapy and ctDNA negative, the survival was 92.5 months. And those who were ctDNA positive and received chemotherapy, their survival was 86.4%. And those who have not received adjuvant, the survival must have been low. So the conclusion of this trial was, the result of this trial suggests that a survival benefit from adjuvant chemotherapy may be obtained in that subgroup of stage 2 colon cancer who has a detectable circulating tumor DNA after surgery. And treating only the patient who have detectable ctDNA reduces the percentage of patient of receiving. So we can minimize the use of adjuvant chemotherapy in these stage 2 high risk patients if we do a ctDNA assessment. So this was Garden Reveal 21 study, clearly stating that the probability of survival is higher when ctDNA is not detected as compared to the blue graph, where ctDNA is not detected as compared to the red graph, which is far more less. So survivability changes if there's a circulatory tumor DNA. So 3 trials, PEGAS trial, oxaliplatin escalation and de-escalation on the basis of ctDNA. The ACT3 trial, which says additional treatment after standard adjuvant chemotherapy on the basis of ctDNA, MSI high, BRAF or BRAF negative, and MSS. So it's a confusing study, but yes, if you go down deep into the study, and the very famous COBRA trial, which says that 1400 resectable stage 2 colon cancer, randomized to active surveillance versus ctDNA directed adjuvant therapy. So there was a trend towards survival benefit when adjuvant chemotherapy was given. So the slide of the day is, we can't throw every resected colon cancer patient under the chemotherapy bus. We call ourselves precision oncologists, so we ought to do better if this test is available, and this test is actually available. We need to learn from our breast cancer practice to develop a tool like Oncotype DX. So far, tissue genomic signature have not been successful in predicting whom to avoid, but yes, this ctDNA approach to select patient for adjuvant chemotherapy appears promising, and we have to see the long-term role of ctDNA. So this is a conclusion of adjuvant therapy. IDEA 3 months, 6 months Kpox, and we have been modifying this IDEA trial of using FOLFOX for 3 months, which is an alternative to Kpox. And yes, decision of adjuvant chemotherapy should be done after detailed discussion, the MSI, MSS status, circulatory tumor DNA, detecting high risk in stage 2 and detecting low risk in stage 3. So we should be wiser enough to choose which patient to give adjuvant chemotherapy and not overuse it and not underuse it. And for the survival benefit, So here is the role of neoadjuvant chemotherapy. So two trials, Prodige and Foxtrot. So what was the selection criteria? What was the basic fundamental of neoadjuvant? Same as any other solid cancer. Earlier eradication of micrometastatic disease, decrease the size and stage of primary tumor, and we'll discuss locally advanced colorectal tumor. What are those? And concept of cytotoxic debulking with NAC. The tumor cell shedding could decrease during surgery. And the locally advanced colorectal cancers for the purpose of clinical trial was colon cancer has been defined by radiological T stage, high risk T3, more than 5 extramural invasion to pericolic tract and T4 primary tumors. But yes, the concept and surgeons won't agree to it. They won't. Surgery induces growth factor activity, which may enhance micrometastatic progression. I mean, this is a common with a journal. Layman public also has that surgery or a biopsy increases micrometastasis. But yes, the concept of neoadjuvant chemotherapy in colorectal comes with that also. So this is a Prodige 22, a neoadjuvant FOLFOX4. FOLFOX4 plus cetuximab, which has been tried earlier in adjuvant setting as well, versus immediate surgery. So it was 1:1 randomization of 104 patients of high risk T3, T4 or N2. And the primary endpoint is tumor regression grade, TRG, which is something new in colon cancer. So TRG, just a minute. So TRG1, TRG2, TRG3, we need to spend 1 minute on this. TRG1 was no viable cancer after chemotherapy. TRG2 was cancer outgrown by fibrosis. So TRG2 is better than TRG1 is better than TRG2, and TRG3 is significant fibrosis outgrown by cancer. So if we have TRG1 and 2, it is called a significant tumor regression, and we can see this in Prodige 22 that the amount of significant tumor regression was 44% versus 8%, a very high significant p-value. Just a minute. Yeah. So this conclusion of this Prodige 22 was in patient with locally advanced colon cancer, neoadjuvant FOLFOX was well tolerated in perioperative settings. Neoadjuvant FOLFOX compared with upfront surgery did not increase surgical morbidity. I mean, it's a safer thing, and was not associated with TRG, but was associated with TRG1 and TRG, which was significant tumor regression. The 3-year DFS and the 5-year OS has to be assessed in phase 3 studies, which are going on. And this is famous Foxtrot ASCO 20 or 19 it was. So neoadjuvant was well tolerated and safe, with again emphasizing on no increase in perioperative morbidity, and a trend towards fewer serious postoperative complication. The histological regression was seen in 59% of the patient receiving neoadjuvant, including pathological CR. So this term is also coming in colon cancer. The result in marked histological downstaging and halving of the rate of incomplete resection, which is important in colorectal. Observed an improvement in 2-year failure rate, hazard ratio of 0.77, but this study was falling short of statistical significance. So p-value was not significant, but we can see the no increase in perioperative mortality and histological regression. So neoadjuvant chemotherapy for colon cancer improved surgical outcomes and can now be considered as a treatment option. Longer follow-ups are required, obviously, and further trials are required to confirm the long-term benefit. But if I recall my last decade of practice, so I would suggest that I had given neoadjuvant chemotherapy, particularly in transverse colon when it was a retroperitoneal colon, like sticking towards the base of like stomach bed and all. So a bulky colon cancer with the node positive on imaging, particularly in transfer colon, I can still recall 5-6 patients who am given FOLFOX before the surgery. So these are ongoing trials, and amazing literature is coming. Even ipilimumab, nivolumab, celecoxib, pembrolizumab before surgery. I'm not talking about only FOLFOX. So FOLFOX, cetuximab. There was in Foxtrot, there was a bevacizumab arm with also, and torpelam, FOLFOX. So various things are going on in neoadjuvant cancer therapy. So neoadjuvant therapy will likely find its niche in the treatment of locally advanced colon cancer as data will unfold. It is particularly teasing out which population are likely to benefit through molecular characterization and radiographic response. Avoiding operative delays in those who have a low likelihood of response to cytotoxic chemotherapy will be imperative. And the inclusion of novel approach with immunotherapy or other targeted therapy outside a traditional chemotherapy practice could provide a significant survival advantage, and with a personalized approach to this stage 3 operable colon cancer. Thank you so much for patient listening, and over to the organizers.
Thank you, Dr. Ankur. Wonderful summarize, all slides, good explanation. And there is one question in the chat box. Which patient will you select categorically for your neoadjuvant chemotherapy on imaging basis?
Yeah, so on imaging basis, I know that T staging is, so images specially characterize T staging better than N staging. But yes, those patients who have a bulky disease, T3, T4, and particularly if lymph nodes are appreciable and the bulk of tumor is much and there's no impending obstruction or perforation. So when the patient has good performance status, so I would consider those patients if I have to, but we have to wait for the long-term results of Prodige and Foxtrot. But yes, those patients who have a bulky lymph node and T3, T4, and patient allows that time of 4 to 6 cycles, I would, if I have to give, I will choose such patients.
I mean, completely agree with you. So basically the T4B tumors. So with the adjacent organ involvement, like in a female, if the ovarian infiltration is there and like bulky nodal disease, where, yes, I mean, in young patient, you would actually wish to control that systemic burden for a couple of weeks and then go for surgery. In those patients, I think you are, comfortable choosing neoadjuvant as of the data available till date. So Dr. Ankur, one more question in the chat box. Should one do mutational analysis on biopsy prior to neoadjuvant? Do you suggest?
Yes, I mean, a very valid question. And if given a choice, why not? If I'm going for neoadjuvant and there are papers of neoadjuvant with cetuximab, neoadjuvant with bevacizumab, I'm very much interested in BRAF status and MSI, MSS status in my neoadjuvant setting. And I'm very sure in next, not 2-3 years, you will have data of immunotherapy in neoadjuvant settings also. And there are many trials of Pembro and Nivo-EP combination. So yes, once we know the status, MSI, MSS status, BRAF status, so the world is moving towards immunotherapy, and I would like to assess mutational analysis, a molecular analysis in a neoadjuvant setting as well, which I do very commonly, almost 100% in my metastatic colorectal cancer.
Yeah. So what message, are you passing, if I understand correctly? So to select your patients whom to give chemotherapy or whom not to, you wish to go for mutational analysis, but your decision of adding biologicals will not depend on in stage 2 and 3.
Yes. I mean, we are too early and in infancy to actually practice this targeted therapy with chemotherapy. So we have still not, I would like to hear in panel discussion, we are still not practicing neoadjuvant chemotherapy, but this is a concept which will emerge as in other solid cancers.
Right. And how is the response to neoadjuvant therapy assessed? PET-CT or CECT? What would you like to do?
I don't know the actual answer to this, but yes, practice is moving towards PET-CT scan with contrast, with oral contrast. So I would like to go for a PET scan rather than a CCT. I mean, it comes with almost same price in any setting.
Right. Apart for certain biologies like mucinous, where we, do not expect a much uptake at the baseline. So the dictum is what you do at baseline, you compare the response with that scanning only. It's easier for you to actually derive.
So the concept of neoadjuvant chemotherapy is something different. It is not doing, it has proven that it does not increases perioperative morbidity. Right. It gives some histological regression, which may or may not turn into a DFS or an OS advantage. But yes, it is not unsafe. It is doable. And it is not inferior if it is not superior. So what I recall of my neoadjuvant, whatever in setting which I have given in last 5-10 years, is stable disease. I mean, it could, I have not seen a drastic response, but yes, a stable disease, and surgeon has gone back and resected those 3-4 transverse colon. I recall 3-4 transverse colon, which was like advanced and going to the base of stomach bed. So it was stable disease, and surgeons were successfully able to operate it.
Right. And one more question is there. I'm not able to understand what exactly does he mean to ask, Dr. Anand Narayan Singh.
Yeah,
So
yeah,
do you
she's
choose?
yeah, transverse colon. This is transverse colon.
Okay.
So
Do
do
you
you
choose
choose
retroperitoneal
retroperitoneal
conal or
colon or an
intraperitoneal conal?
intraperitoneal colon for neoadjuvant? So I didn't knew this question will come, but yes, my experience of 5-6 neoadjuvant chemotherapy prior to Prodig and Foxtrot
Okay.
was that transverse colon concept, which is probably retroperitoneal.
All right. And how about management of disease that progresses on neoadjuvant therapy? Should we go ahead with resection or consider it biologically aggressive?
A very difficult one. So the management of progression on neoadjuvant therapy, if it turns to be a metastatic one, unfortunate, especially look for BRAF mutation, because these are those patients who will not respond. And should we go ahead with resection or consider it as a biological aggressive? So yes, colorectal cancer, if it is a oligometastatic or a frank metastatic, but this subset of patient will have a poor prognosis. I really don't know the answer whether it should go with resection or consider to be a biological aggressive. Yes, there are biological aggressive, and I would still go for resection if given a chance, because this is way where I can achieve some cure, 5 years survival of 15-20% even. Yes.
Yeah, I completely agree. So if it is a local progression, still the scope of surgery is there. If R0 is possible, I think we should consider
So Anand
that.
Narayan has saying that thanks transverse colon is intraperitoneal. I think a surgeon, I believe Anand Narayan Singh is a surgical expertise. Yes.
Yeah.
So but I have my experience in transverse colon only.
Right. So thank you, Dr. Ankur, for a wonderful presentation and question answer session. So we move on to the panel discussion. Please stay back for the panel.
Yes, I will.
Yeah, Dr. Nagender, please take over and invite your panelists also. Dr. Nagender, are you there?
Yeah,
please unmute
Shefali.
yourself. Yeah. Please invite the panelists and you can take over. Yeah.
Right. Can you stop sharing? I think I'm not able to share my slides.
Yeah, Dr. Ankur, please stop share kar dijiye. Dr. Ankur? Yeah. So, Dr. Nagender, you can share your screen now.
Right. Just once again.
Still not able to see your screen?
Yes, I can. Now I think it's visible, right?
Yeah.
Okay then.
Yeah, it's visible. Yes. So, isko full screen aap kar lijiye.
Right. Sure. I think the slide is full screen, right? So thank you very much for giving me the opportunity, Dr. Shefali. I think my slides are visible and my voice is audible, right? I was listening very carefully. Dr. Ankur, Bahl have so beautifully delineated and so many new things I've learned. So I think you have made my job easy, and I will come straight to the presentation. So the topic allotted to me is the panel discussion for neoadjuvant and adjuvant strategies for colon cancer, and where are we as far as real world scenario is concerned. So I will come straight to the point. Before that, my disclaimer that the cases are arbitrary to discuss the topic of relevance. So I will come straight to the point. And first of all, I would like to invite my expert panelist. Dr. Ankur Bahl sir is there, I have seen, and Dr. Saphalta, Baghmar, are you there, ma'am?
I'm here.
Right. Please unmute yourself and come on screen. And Dr. Viraj, Lavingia sir, are you there, sir?
Yes,
right. I can see you. Dr. Prashant Gupta sir, right. Dr. Prashant sir is there, right, sir?
I'm here, sir.
Right. So I can see all my expert panelists. So I don't want to introduce any of them because all of us have listened to them in so many platforms. So I will come straight to the present because of limitation of time. First case presentation, like 52-year-old male presented with the complaints of altered bowel habits and abdominal pain for past 1 month duration. There was no family history of malignancy. Patient was in good performance status, ECOG performance status 1. And the CT abdomen and pelvis was showing a short segment wall thickening in the proximal right transverse colon with a few small mesocolonic lymph nodes. colonoscopy was performed, which showed a friable growth in the same location. The biopsy was contemplated, and the report was that it was an adenocarcinoma colon. And upfront serum CA was 24, right? Patient underwent right hemicolectomy and lymph node dissection. The histopathology came out to be PT3N0, margins are clear, and the post-operative recovery of the patient was uneventful. I think the case is very much clear. So, so it is a stage 2A carcinoma colon. So my first question is, what additional assessment is required to ascertain the further course of treatment? May I ask Dr. Saphalta first?
See, this is just stage 2 disease, 2A disease. I would like to see if the patient is having MSI high or MSS stable. So this is the only thing which I'll be assessing in this patient. Yes, that's it.
Okay. May I ask Dr. Viraj Lavingia, is it only MSI which you are interested in, or anything else you want to go in this type of scenario?
Yeah, so I would definitely like MMR testing by IHC. And also I would like to know exact number of lymph nodes that were resected to call it N0. We would also like to know LVI, PNI, and what was the grade of the tumor. And was there any perforation on the tumor specimen? Because you said it was friable on colonoscopy. So these all things multiple would make it a high risk stage 2, and then we can make a case for giving some sort of adjuvant therapy.
Absolutely, sir. Perfect answer. So I just want to know, like MSI testing, as everyone have told, that MSI testing have to be done. So are we justified enough only to do IHC, or whether you will go for PCR or NGS if affordability is not an issue? So may I ask Dr. Ankur Bahl, sir, in your practice, whether you are going with IHC only, or you are going additional advanced panel testing?
Yes, Nagender. First of all, the previous question, which I will agree with Viraj. So in stage 2 colorectal cancer, of good history, endoscopic examination, and talking to your pathologist, probably we'd like to regross it and check the grossing status and the number of lymph node. At times, when we ask the lymph node resection, I mean the adequacy of the lymph node resection increases. But yes, your question, the MSI testing, it's a divided house. I prefer IHC, and we take a proper history, familial history. We talk to a molecular oncologist, Lynch syndrome and all. But yes, we prefer IHC, a good IHC. But in few patients, we have gone beyond IHC and done a PCR also. So at this point of time, I agree with Viraj. I would be happy with IHC in stage 2 colon cancer to make it easy and doable.
Perfect, sir. So may I ask Dr. Prashant Gupta, sir, because he's a surgical oncologist in the panel. So because a lot of patients you are operating, sir. So what is the percentage of MSI high or deficient MMR in your practice? Like whenever you operate a patient and when we send for all these tests, which everyone have told that IHC is good enough. So in how much percentage of patients of stage 2 you will get MSI high, and how many patients of stage 3 colon cancer in your practice you are getting? What is the percentage? Can you throw light on that?
So hard to say, sir. MSI testing we are doing regularly by IHC only. But then after that, the patient goes to medical oncologist. So
okay, fair enough.
Collect the data for what percentage of MSI are coming as possible.
Right. So Dr. Saphalta, what is your practice? So in how much percent of patients of stage 2 and how many percent of stage 3 you will get MSI high?
See, in stage 3, I haven't got MSI testing done, but yes, in stage 2, it is like 5 to 10% of the patient do get MSI high.
Okay, so MSI high, there are some reasons why we are looking into it, because majority times MSI high patients will be right-sided, they will be high-grade, mucinous, there will be increased peritumoral lymphocyte infiltration, they will be majority times diploid, and large primary nodes negative, and better long-term prognosis is there. That's why you can get away without doing chemotherapy, right? MSI high usually will not go ahead with that. So Dr. Viraj sir, I think you must have seen so many patients with MSI high. So in your practice, in stage 2, how much percent of the patient you will get by and large MSI high, and you will tell that, okay, this patient is not for chemo, and you'll go ahead with the surveillance, or you'll keep the patient on follow-up?
Yeah, so in my practice, it is almost as high as 1 in 15 to 1 in 20. 15 to 20%. So that is 1 in 5 to 1 in 6 patient for stage 2. That's pretty high MSI that I see, but that's, I think, so concordant with the literature that we have from West. And for stage 3 also, we have about 5% tumors which are coming MSI high. That is 1 in 20 patient would turn out to be MSI high. But right now we don't use that to select chemo or not give chemo.
Right. So may I ask Dr. Ankur Bahl, sir, in your practice, MSI high, because very, very important, because that's a very, very important point to make sure whether we have to give the chemotherapy, whether it's Capox, Folfox, or single agent capecitabine.
Yeah,
right?
Not actually, to be very honest, not assessed number of patients, but yes, Viraj number looks slightly high. I would say 5 to 8% or 8 to 10%, not 15 to 20% certainly.
Fair enough. I do agree. Even in my practice also, it is around 5 to 15%. But yes, I do agree with Dr. Viraj, sir. So maybe it will hover around 1 in 5 or 1 in 6. So coming to next, so we will divide stage 2 into high risk and low risk. And we know that there are 3 ASCO, NCCN, and ESMO in which T4 primary tumor, inadequate lymph node sampling less than 12, poorly differentiated or undifferentiated tumor, perforation of front, clinical obstruction, LVI, PNI, close, intermediate, or positive margins, high probability CA. These are all high risk indication by which we will decide whether we have to give chemotherapy to this subset, because as we know that Mosaic trial have already shown that there is a defense advantage and oral survival also. So I just want to ask, like NCCN also have clearly told that in patients who are having no high risk features of stage 2A, MSS or proficient MMR, you can do observation or single agent capecitabine is good enough. And those patients T3, N0, M0, stage 2A, high risk for systemic recurrence, you can go ahead with chemotherapy. And low risk stage 3 also, you are very much clear that you have to go ahead with 3 months or 6 months of Capox or Folfox. So I will make the discussion a little bit more complicated. I will go ahead because of the real world scenario. We all know this for our DM days, but in this type of scenario, when you are having a 8th AJCC stage 2A, you can look at, I will come to each one of you and I will take your inputs. If the patient is having a PT3, N0, M0, all are stage 2. First scenario is patient is having a poorly differentiated adenocarcinoma, margins are negative, LVI, PNI is negative, patient is deficient MMR, MSI high, but preoperative CA is 110, right? So my first question is to Dr. Saphalta, high preoperative CA. What is the cutoff for high preoperative CA for you? We know that it's up to 3, which is taken as normal. So what is your high preoperative CA?
See, by this, except when we just ignore CEA, rest of the things, I don't think so there is any indication of chemotherapy in this patient. But yes, depending on the CEA, I haven't decided yet any time to give chemotherapy to the patient. So
patient is poorly differentiated, Dr. Saphalta.
Poorly differentiated carcinoma in MSI high is not considered as a risk factor. This is one thing which is like ignored in these patients. So I had never done given chemotherapy in a patient who is having high CEA.
Okay.
This
so
is a new thing for me.
High risk feature also you will divide into major and minor. That CEA high and poorly differentiated histology. If the patient is with deficient MMR and MSI high, you will not go for chemotherapy in adjuvant setting.
Whenever, that's what. If the patient is having T3N0, yeah, or if like high, you are counting high risk features. So poorly differentiated carcinoma in MSI high is not considered as a high risk feature. And if it is MSS stable, in that case, poorly differentiated carcinoma is considered as a high risk feature, one of the high risk feature.
Okay. May I ask Dr. Viraj, sir, in the first scenario, what will be your take, sir?
No chemo. No chemo for first. CEA preoperative has no value. If it's a postoperative CEA, that makes a poor prognosis. So that's an important point. And if MSI is high, none of the high risk factors except the T4 status or inadequate lymph node staging would matter. Whether it's LVI, PNI, we would just not give them chemo because risk of recurrence to these patients is extremely low and there's no benefit of giving added chemotherapy. But the difficulty becomes if you make this case a T4 and then then it makes a
I will come to that, sir. I will come to T4. First, we'll stick to T3 only. May I ask Dr. Ankur Bahl, sir, Is this the same practice? So in first scenario, so are we having consensus in our panelists that we will not go for chemotherapy so that I can move for the second scenario?
Great as a
Ankur, well, sir. Ankur, sir, are you there? I don't think sir is there. Dr. Saphalta, I have already taken your bit. Dr. Prashant, sir, are having any same inputs or anything you want to add?
Same, sir, same.
The first scenario, we are not going to give chemotherapy.
Operative CEA, I would like to repeat. Otherwise, as per this profile, I think chemotherapy is not warranted.
Perfect. Coming to second scenario, patient is having a stage 2A, moderately differentiated adeno, margins are negative, LVI-PNI negative, proficient MMR or MSS, CA also is in normal range. So in this type of scenario, whether you will go ahead with chemotherapy, may I start with Dr. Saphalta again? Dr. Saphalta, are you there? I think Dr. Saphalta is not there. Dr. Viraj, sir, you can take
Dr.
this.
Saphalta is probably on mute. Dr. Nagender.
Yeah, can you unmute Dr. Saphalta? I can see her also in the.
I'm there. My kid is now started crying.
Okay, okay. No issues, no issues. Dr. Viraj, sir, you can take for the time being.
Yeah, so in majority of times, this patient in my practice would go on observation. Having said that, I always discuss single agent capecitabine to these patients based on Webisode study. Although 2 to 3% absolute difference in survival benefit with single agent fluoropyrimidine was shown in stage 2. Although low risk, I agree. Well, we do offer, but I completely agree. This patient would 9 out of 10 times would go on observation in my practice.
Okay, so even if it is proficient MMR, rest all the indications are negative, so you will go ahead. So suppose the patient comes out with BRAF positive, whether you will change your decision or based on the BRAF medicine, because NGS, sometimes we will do NGS upfront and you will pick up a BRAF medicine in a stage 2 also. So that will change your decision, sir?
No, absolutely not. Currently, there is no evidence to suggest KRAS, NRAS, BRAF to guide our treatment decisions in adjuvant strategies.
Perfect. Fair enough. I do agree with your point. Coming to the third scenario. So patient is having stage 2, well-differentiated adeno, margins negative, LVI-PNI are positive. Patient is deficient MMR, MSI high, and the preoperative CA also, as you can see, it is 110 again. So first of all, my question is to Dr. Saphalta, if she's there. So are you doing preoperative CA and post-operative CA also if it is high in the preoperative setting, or is it a regular practice, or you're selective in your approach? Dr. Saphalta, if you're free.
Just crying.
I'm back.
Okay.
Yes. What is the question?
The question is, in this type of scenario, like the third point, patient is having a stage 2A, well-differentiated adeno, margins negative, LVI-PNI is positive, deficient MMR, MSI is high, preoperative CA is 110. So in the patient who's having a preoperative CA of 3 digits, whether you are again doing post-operative CA before starting adjuvant chemo?
I'll do CA, but then I won't be changing my decision, because LVI-PNI is one factor which, even giving chemotherapy when the patient is having proficient MMR, has not shown a benefit as such. It is one of the minute things which is there. Now, having so much of CEA, probably after surgery also, if we see for circulating tumor DNA, in that case, probably will come high, and right now we are not having proper guideline to judge this thing, use ctDNA to give chemotherapy or not, though the trial has shown some benefit in the patients who are having ctDNA positive and having high risk features. So, but presently I will not give chemotherapy to this patient.
I just want to mention here that this patient presented with altered bowel habits, right? So probably this patient may be having a partial obstruction, right? So whether in point number 3, whether you will give adjuvant chemotherapy in this type of scenario, even if the patient is having MSI high?
Altered bowel?
PNODC is anyway high.
Altered bowel habit, of course, any patient will come with the altered bowel habit. Most of the patient will come with in CA colon. So I will not be deciding chemotherapy based on that. It is not on obstruction as such.
No, whether right-sided or left-sided, stage 2A, whether your decision, where is within sidedness in early stage, like stage 2 or stage 3?
No.
So sidedness and the mutation analysis is not having any impact as far as decision making is concerned, right, sir?
As of now, no.
Right. Your take, Dr. Viraj, sir, any input you want to?
No, so I agree. If MSI is high, none of these patients would go on chemotherapy, whether it's LVI positive, obstruction. Post-operative CEA, however, is a very interesting development. There are few % of patients who, like if you have a pre-op 110, would come up with 8 or 9 or 10 CEA or 15 CEA. And then it's a big discussion that what to do, because that certainly is a poor prognostic factor.
Right. Absolutely right. I do agree. I think we are having consensus here. And last scenario is that patient is having a PD3 N0 M0, poorly differentiated, margins negative, PNI is positive, LVI is negative, deficient MMR, MSI high, and CEA is again 25. So whether CEA 25, you will take it as a high preoperative CEA, Dr. Saphalta. You are having a softer indication of PNI positive, and patient is having poor different histology. Whether you will go ahead with chemo in this scenario?
No.
So I think none of this scenario you are giving chemotherapy, right?
No.
Is it correct? If the patient is having a BRAF mutation positive, that also is not going to change your management, right?
No. As such,
see, life is tough. It's not be so many various permutation and combinations will be there in real world scenario, and we have to be very, very judicious in taking our approach. That's why I asked MSI relevance. And when we are seeing this type of report, because I think you must be facing the same scenarios in your practice too, because this is what I am having so many doubts. That's why I put this case. Dr. Ankur Bahl is there, sir? Dr. Ankur Bahl, sir? I think he's not there. So, okay, so I will come to the next scenario. So sidedness, already you told that so there's no much difference whether you're a right-sided or a left-sided colon cancer as far as adjuvant therapy is concerned. Second thing is, what will you do, which Dr. Viraj sir have asked me, that what you will do if the patient is having T4N0, all other risk factors are negative, but the patient is having MSI high and deficient MMR. And is there any role of oxaliplatin in this type of scenario? So may I ask Dr. Prashant sir, if you can take this question, sir? Dr. Prashant Gupta, sir.
Sir.
So if the patient is having a T4N0 and all of the risk factors are negative, but MSI is high, whether you will go for capecitabine alone, whether you go for capox, Folfox, or surveillance itself is sufficient because other risk factors are negative.
So young patient, as a surgeon, I would like my medical oncologist to consider chemotherapy in this patient. As it is a T4 disease, I would definitely like to consider chemotherapy. Probably
okay.
not
I got your point.
Unlikely to be really effective. So maybe capox or Folfox. That is up to the medical oncologist to decide.
Right. So Dr. Viraj sir, I think this was your question, the point which you want to make. Now you can please enlighten us.
Yeah, so T4 or dissection and MSI high, this patient would go on a capox or Folfox, but mainly capox in my practice. Because we know, although retrospective evidence that 5FU may be not working in these tumors, although that is a questionable and arguable statement, nevertheless, for T4 status, we know it's even worse than T3N1. We use a doublet chemotherapy for this patient.
So we'll go ahead with doublet chemotherapy.
But 3 months, only 3 months, not 6
3 months. Fair enough. Fair enough. So this was the evidence which Dr. Viraj sir clearly told that efficacy of adjuvant chemotherapy in colon cancer with microsatellite instability, a large multicenter AGOG study, AGEO study was published, in which they have shown that those patients who have got a MSI high or microsatellite instability, they have got a benefit if you have used oxaliplatin along with capecitabine for 3 months. That's fair enough. Okay. Any other biomarkers, Dr. Viraj sir, whether you will look into it, or is this information of MSI sufficient for you for taking your decision in adjuvant setting?
Sufficient. I do only MSI in stage 2 and 3.
Okay, fair enough. So adjuvant 5FU leukovorin oxaliplatin in stage 2 and stage 3 updated 10-year survival and outcomes according to the BRAF mutation and MSI repair status of mosaic trial was published, and they have shown that those patients who are even having a BRAF mutation also have got benefit if they're having both a DFS and OS advantage if you use Folfox, and hazard ratio was statistically significant 0.48 and 0.41. So last 20 years, as Dr. Ankur sir have very clearly demonstrated that initially 2 decades back, there was no adjuvant treatment for stage 2, and over a period of time when monotherapy came into existence in 1994 to 2005, and then polychemotherapy came into mosaic trial 2004 and Xeloxa trial in 2010, and there was a 3-year DFS advantage. From 52% we have reached to 71% as of now. Are you going for immunoscore in your practice? In affordability is not an issue. Dr. Viraj sir, can you take this question? It's having a good reproducibility. Please, you can take it, sir.
Yes, the immunoscore can be done easily, provided we have a training of our pathologists. Having said that, I don't know any center in our country uses this regularly, if at all. So I don't use this in my practice, but definitely this is a cheaper way than ctDNA testing in the current standard. I spoke with one pathologist that installing this software and working their training of this could be very difficult. So I don't know. Since we are not pathologists, we can't say technical things about it, but a clinical side of this definitely looks very wonderful. High immunoscore, very good prognosis. You don't need chemotherapy, just like you showed there.
Absolutely right. So this was a very, very important point. I do agree with Dr. Viraj sir because it has not yet come to the pen of medical oncologists, but it is an exciting field right now that those patients who are having a low immunoscore, MSI, MSS low immunoscore, MSI high, all these subsets have to be carefully looked into it, and based on that we can take over judicious decision making for extending the DFS advantage which this patient is having. Okay, ctDNA, may I ask Dr. Saphalta? So this is also a new kid in the blocks, the ctDNA. So those patients who are having ctDNA high, we know that the relapse percentage will be on the higher side. 78% of the patients who are having a ctDNA positive, they will relapse, as compared to those patients who are having ctDNA negative in stage 2, relapse only in 10%. And as we see from stage 3 plus, the relapse will be 70% in ctDNA positive patient, and the relapse will be just 12% in ctDNA negative. So whether are you doing this, or are you up for it in the patients in which affordability is not an issue?
Yes, I would like to offer to my patients ctDNA, but yes, when the ctDNA comes positive, it is very easy for us to decide about it that we have to give chemotherapy. But if ctDNA comes out to be negative and the patient is having baseline high risk case, in these patients they have shown recurrence. So we will not be able to decide about chemotherapy when it is ctDNA negative. So, and with the high risk patient, then it will be a controversial thing for us in that case. So yes, I will do this investigation to my patient.
Perfect. So I think this is an upcoming field, and we all should discuss this and document that in our clinical notes in the OPD only that we have discussed. And if the patient is having affordability and if it is available, accessibility also is there, I think we should recommend for all our patients, right? So one more question to Dr. Viraj sir. Sir, in your practice, are you doing DPD testing as a mandatory test before starting 5FU or capecitabine in the patients who are eligible candidates for adjuvant chemotherapy?
For stage 2, I've started doing for all. In stage 2, where I'm going to give chemo, where it is just 2-3% benefit, there I'm doing it for all.
You're doing it for all, and you're taking your decision based on that?
Of course, so if there is a DPD deficiency, for that 2%, I'm not going to give them 5FU or capecitabine.
Perfect. Whether they are eligible candidate as far as histopathological or biomarker statistics is concerned. In stage 2. Yes. Perfect. Perfect. Dr. Saphalta, I think do you agree with Dr. Viraj sir? Anything you want to convey?
He has made a point, but I haven't done like this before. I would, if the patient is indicated to give chemotherapy, I'll be giving. I will not do it. Once the patient develops, after first cycle, patient is having side effects, adverse events, then in that case, I'll certainly do the DPD. Otherwise, I will not do.
Right, right. So has anyone used a nomogram or gene expression assay like coloprint or oncotype DS colon in your practice? Or are you aware of these terms? And I think Dr. Viraj can take this question.
So I'm aware of these, but they are not reproducible. They're not commercially available. What is commercially available is what Dr. Amit Agrawal is writing in the chat box is Guardant Reveal testing, which is a tissue agnostic testing. I would have loved to answer your previous question about ctDNA, take on ctDNA. The test that you showed, Dr. Jeannie Tai's test, is a patented product. It's not commercially available. And it's a tissue based test, means you need a prior tissue biopsy, and you do NGS on that. Then you do operation. Then you do NGS again on day 28. And then you wait for the report. It comes on day 50. And then the NGS, so it's based on the patient's own mutations. So if those mutations are found after operation, that is called as ctDNA positive. While the other test, what I was talking is a tissue agnostic test. That means just like a simple blood test, you don't need a prior mutation testing. It's a broad panel like Guardant 360. This is Guardant Reveal. You do on day 28, the report comes in 10 days. If it is positive, the risk of recurrence is 100. In fact, I was hearing what Dr. Saphalta said, that if it is positive, the decision is easy. In fact, that's my nightmare, that if the test comes positive, you do whatever, this patient is going to recur. And that's not a good condition to be in as an oncologist. If it is negative, the negative predictive value is only 60%. That means you would be right only 6 out of 10 times. So that test is still not polished yet. But if you tell, we have to use it, and that is a commercially available test in India, 2 lakh rupees test. But I have offered it also to VVIPs, but barring those, I don't think so. It's a standard practice yet.
Perfect, sir. Perfect. So this is a valuable insight, because we have not used that, but we are well aware about this. This have to be done in correct clinical setting. So I just want to come to, because we are running short of time. So there is one MSKCC nomogram also, in which age, CEA, number of negative nodes, number of positive nodes without adjuvant chemotherapy, number of positive nodes with adjuvant chemotherapy, tumor location, differentiation, LVIPNA, all were taken into consideration, and nomogram predicted the probability of 5-year freedom from recurrence. So this is also going on, and we are also up for that. There are multiple coloprint tests are available. There is only FDS colon cancer assay. These are the latest insight. And there is one more thing: identification and construction of combinatory cancer hallmark-based gene signature sets to predict the recurrence and the chemotherapy benefit in stage 2 colon. So as you can see in the slide clearly, that those patients who are having a high risk, they are having a very good advantage, although they have not taken the MSI testing into in this. So I will come quick because we are running short of time. I think doctor will stop me, but even then I will quickly come to second case. So 61-year-old male, diabetes, diabetes, hypertension, underwent right hemicolectomy, lymph node dissection for colonic mass, histopathology, PT, N1. Margins are clear, TL9, LVI is positive, and proficient MMR, MSS. So what factors help you to choose CAPOX versus FOLFOX 4, 6, and 7? Whether you are using FOLFOX 6 or 7 also, and what is the duration? So Dr. Saphalta, can you take this question quickly, because we are running short of time?
See, T3 and 1. Here, I would like to give this patient 3 months of adjuvant chemotherapy. And whenever you discuss with the patient with 3 months versus 6 months, every patient will think of 3 months only. And if 3 months, in that case, FOLFOX for 3 months is yet not advisable by the IDEA trial. So I would go ahead with the CAPOX. And recently, a KCSG trial was published in NEJM also in June, and it has shown that the patient who, if you are willing to give 6 months of FOLFOX, we can give just 3 months of oxaliplatin, and rest of the 3 months, 5 of you can be continued. And it has shown similar survival benefit if the patient is willing to take FOLFOX.
Patient is DPD deficiency. What will be your take in that scenario?
If the patient is having DPD deficiency, in that case, I would not like to give FOLFOX or CAPOX. In that case, I will be giving this patient single agent irinotecan.
Do you agree, Dr. Viraj, sir?
No, irinotecan in at least 3 randomized studies have shown 0 benefit completely zero. I think so. Patak and other two, I don't remember, but complete irinotecan is dusted, not for adjuvant. What I would do in if it is a DPD, and fortunately I've not found a case like that because I don't test in stage 3. But what I would do is use the newer fluoropyrimidines, especially the S1 now in the country, because it just behaves like DPD deficiency, because it just increases your tissue concentration of active 5FU. So I would use SOX chemotherapy. What Japanese use? Japanese don't use K-POX, they use SOX. So I would probably go for SOX. But you see, this is the reason why I don't test DPD in stage 3.
Your point well taken, sir. I understood your point, what you are coming up. Only one more thing I want to ask.
One way of doing is you give 50% of the dose of 5FU or this and see the patient if the patient tolerates. This is one way. Actually, I have seen this kind of case and I discussed with Dr. Atul Sharma what to do with this patient. And at that time, S1 was not there in the country. And he said, give irinotecan, single agent irinotecan, at least you have data, but single agent oxaliplatin, you don't have any data.
Okay, fair enough.
Might as well then keep on observation because that's what you're doing with single agent irinotecan. There's no benefit.
And one more question I just want to ask, we are running a lot of short in time. So we know that the LV potentiates 5FU bolus. It won't potentiate the infusion. So whether if you are using FOLFOX and for using for 6 months as per IDEA analysis, are you using, you got your point, Dr. Viraj sir, whether you'll be using LV when you're not using bolus?
I don't. I've stopped using LV since last 2 years.
Right.
In Dr. Saphalta? My cases. What is it?
So, Dr. Saphalta, whether you will use LV when you're not using bolus 5FU in a patient who's not in merit for that?
No.
Okay, you're not using LV. Have you used a FOLFOX 7 in any of your adjuvant setting, or you are doing it in any setting, whether metastatic or?
No.
No. Okay, fair enough. Have you used capecitabine in full dose or attenuated doses in your practice? Is there any patients whom you use full dose of 1000 to 1250 milligram per meter square BD, right? No. Okay. So in your practice, are you using home infusion pumps, IPD admission, daycare, and especially in the COVID scenario?
Yes.
Or
yes.
You're okay with home infusion pumps as far as FOLFOX is concerned?
Like it is a routine practice for ours that we use home infusion pumps, and if the patient wants to be admitted in the hospital, then only we admit for 2-3 days. Otherwise, it is home infusion.
Okay, fair enough. So I will come whether that COVID-19, we know that the third wave of COVID is knocking the door. Whether you're doing COVID RT-PCR tonight for all the patients who are ward admission in your practice in this type of scenario, or you are selective, right? Selective, not in all. Okay, so duration of treatment is 3 months, 6 months. I will not go into the details of IDM analysis. We all know that. So I will quickly finish it off because already it's over 8.
One thing is I want to ask Viraj whether if you want to give SOX rather than that, you just give S1, because what I felt is that S1 given alone is good enough, equivalent to FOLFOX sort of.
You could do that. Yeah, I would agree. But irinotecan is a no.
Irinotecan is a no. Okay, fair enough. Okay, sir. So survival benefit
so based on mosaic study. Addition of oxaliplatin even in low risk stage 3, the DFS was hardly couple of percent and the hazard ratio was moving out of 1. Yeah, there you go. It's a 10-year data. Is this a 10-year data? This is a 6-year data.
This is a 5-year and 6-year data.
Show the 10. So the last paper you showed was 10-year data, the BRAF paper. So in that paper, the 10-year benefit in low risk stage 3, it's not convincing. So I agree with you. I could do single agent S1 also. So I have a very low threshold for omitting oxaliplatin in my practice because the neuropathy never comes when you are giving it. It comes when you stop it. And then suddenly patient comes and says, hey, doctor, aap jo junjun pooch rahe the, wo tab to nahi ho raha tha, abhi ho raha hai. So oxaliplatin is a no.
Absolutely right. So I think already we are over 8 now. Just quickly, I will take your inputs. So is there any role of targeted therapy as far as anti-VEGF or anti-EGFR in early stage in adjuvant setting? Dr. Viraj sir can take this.
For adjuvant?
Yes, sir.
I don't use.
You don't use. Fair enough. Because there are 3 large negative trials, as Dr. Viraj sir have told, that we will not use because NSFP C08, Avant, COSAR2 all have shown that there is no role of bevacizumab. You can see the curves in the Kaplan-Meier curve, they are all collinear and there's no overall survival benefit. So you should not use bevacizumab as far as adjuvant setting is concerned. Cetuximab also, if you see anti-EGFR, there are 2 large negative studies, greater than 3,000 patients, N0147 and PITA-CC8 have shown that there is no benefit. This is a negative study for anti-EGFR cetuximab along with chemotherapy in adjuvant setting. So what will you do if the patient is T3N1 but has a tumor deposits away from the primary lesion? So may I ask Dr. Gupta sir this question? Dr. Prashant sir. Right.
Sir, tumor deposit away from the primary lesion means it is in the abdomen itself or somewhere else?
In the abdomen itself, but away from the primary.
Yeah, if it is a single lesion, probably I would go for surgery and remove it instead of directly considering chemotherapy.
Right.
Eradication of disease would be best with surgery, not just with chemotherapy.
So suppose you have done the surgery, PT3N1 is the status, and you came to know after the post-operative imaging, it is a tumor deposit is there. So will you redo the surgery again to eradicate the tumor deposit, or you will go ahead with the chemotherapy with the intensive protocol?
So if it was a single tumor deposit, I'll be going for surgery. If there are multiple tumor deposits, then chemotherapy has to be considered.
Perfect. So Dr. Viraj sir, your input on this?
Yeah, so these are node negative but stage 3 patients. They portend poor prognosis actually. So I would give adjuvant chemotherapy to this patient.
Right. And what will be the duration and what agents you will use, sir?
Oh, 3 months. 3 months.
3 months. Fair enough. Dr. Saphalta, will you agree or you will go ahead with 6 months of FOLFOX?
See, this patient is having tumor deposit away from the primary lesion. That means the patient is having a metastatic disease as such, right?
Okay. But
So
you have picked up.
lesion,
Yeah.
it is not like skip lesion. It can be anywhere. You have given an open question.
Right.
In that case, what I would do is like this patient, if the repeat surgery can be done, in that case, yes, I will like to send the patient to the surgeon again to get the repeat surgery done. If it is not, then in that case, I would like to treat it as like chemotherapy followed by again to reassess up for the surgery.
Perfect. So there is a prognostic value of tumor deposits for disease-free survival in patients with stage 3 colon cancer. There is a post-hoc analysis of IDEA France phase 3 study. This was Prodige Garkor, in which they have figured it out. Those patients who are having a tumor deposits away from the primary side, they are having a poor prognosis and they require a adjuvant chemotherapy, no matter whatever the nodal status is. So I will just come to the end of this presentation. And role of neoadjuvant, we all know that this early eradication to micrometastatic disease decreases the size and stage of the primary tumor, and cytotoxic debulking of neoadjuvant chemotherapy and tumor shedding could decrease during the surgery. This is the role of neoadjuvant chemotherapy. So whether any inputs from Dr. Saphalta is already Dr. Ankur sir so clearly delineated. So are you using neoadjuvant chemotherapy after discussing tumor board upfront for your patients who are not in the preview of surgery upfront?
Come again, please.
Hello.
Your question, please.
Yeah, neoadjuvant chemotherapy approach. You are using routinely in your practice?
No, I'm not using neoadjuvant approach. Only in the case when the tumor is involving some other organ and resection cannot be done. In that case, only I'm using neoadjuvant chemotherapy. Otherwise, in stage 2, stage 3, which can be resectable, is not. I haven't used it.
Right. So they are sometimes known as the tumor which may be resectable may not be operable, and tumors which are operable may not be resectable, because resectability and operability are not interchangeable terms. So sometimes in the tumor board, the surgical oncologists are not keen enough to operate upfront because of the comorbidities, poor performance status, and so many other reasons are there. So that's why I'm asking that, is there any subset of patients in which you will go ahead with neoadjuvant chemotherapy, make it operable and resectable in next couple of months, and then move forward? Because we know that surgery is very, very important modality of treatment as far as extended survival is concerned.
The surgeon, if the surgeon is saying that the patient is inoperable or the resection is not possible, in that case only I'll give chemotherapy. Otherwise, if the patient, if everything
exactly that was my point, which I was trying to extract from you. I think Dr. Prashant Gupta sir, in your practice in your tumor board, what is your input whenever a decision is being taken? In what scenario you will ask the medical oncologist in your tumor board to go ahead with chemotherapy and then you will operate after 2 to 3 months down the line.
If it is a bulky nodal disease, sir, that we envisage that we won't be able to resect completely, then only we take the patient to tumor board, otherwise we take the patient to surgery.
Okay, so Dr. Viraj, sir, just a quick input. When you will be telling the surgical oncologist, sir, stop, I will give you your agent and then you will operate after 2 months. I will send this patient back to you. Your input, quick.
So Dr. Shefali commented on this T4B lesions where the surgeon will have to do multivisceral resections. These are the only tumors where we do as a team neoadjuvant chemotherapy.
Absolutely right. Your point is, you nailed the question, sir. So I think I've come to the end of the presentation. I will not go into the details. Already Dr. Ankur Bahl, sir, have clearly demonstrated this. At the last, the words of wisdom that if we were not for greater variability among the individuals, medicine might as well be a science, not an art. And he who studies medicine or medical oncology without books sails an uncharted sea. But he who studies medicine or medical oncology without patient doesn't go to sea at all. These are the words of wisdom from William Osler. I think it's a multidisciplinary tumor board, and which is the way to extend the survival, in which we can take a decision and increase the survival. So if you want to walk fast, walk alone. But if you want to walk far, walk together. Thank you very much for patient listening. And I will thank all my panelists for their valuable inputs and all the listeners. And over to organizers. Back to you, Dr.
Thank you, Dr. Nagender, and thank you all of the panelists. I think wonderful discussion, equally online and equally in the chat box also. So it's a good thing going on. So Dr. Nagender, these questions are there. I think either of you, Dr. Viraj, Dr. Saphalta, or you can take up. So I think Dr. Amit's question, so Dr. Viraj is being answering for so many long list of the questions and the answers. So there is one question I can see: is there any role for immune checkpoint inhibitor in adjuvant setting, perhaps in frailer patients? So in frail patients who are not able to tolerate, or in elderly, I mean, do you consider at any time point immune checkpoint inhibitor in adjuvant setting? So obviously the select group, but do you really consider it? Any of you can take it.
I think Dr. Viraj can give this answer, because
so
we are not having
definitely
experience
not do it, because I know I can save him anytime if he metastasizes.
Yeah, all right. Okay. Right. And Dr. Saphalta, any difference of opinion?
Agree with Dr. Viraj for this thing.
All right. Okay. And I think the DPD and the discussion of omitting 5FU bolus, leucovorin is still going on. So wonderful discussion, and thank you all for such a contribution and your experience. Dr. Amit, sir, thank you so much for joining. I think your questions have made it more interesting in the chat box. Thank you. And so see you all in the, next month, first Wednesday. So we'll be taking up the next topic in colon. So thank you so much, all of you. Thank you.
Thank you. Thank you very much for the opportunity.
Thank you, Dr. Amit.
Bye-bye.
Thank you, Dr. Viraj. Thank you, Dr. Saphalta. Thank you, Dr. Prashant. And thank you, Dr. Nagender.
Thank you. Thank you, Dr. Shefali. Thank you. Bye-bye.